Welcome to the NCLEX Nursing Huddle. We will be discussing fluid and electrolytes and acid-base balance today. So, ADPI. I always like to begin by mentioning ADPI, the nursing process, which should always govern our thoughts and how we care for our patients. So the A is for assessment, D is for diagnosis, the nursing diagnosis, P is planning, and what we're going to actually do for our patients. The I stands for implementation and interventions, what we are physically going to do, and we actually put those plans into place. The E stands for evaluation, and we always have to come back and look at what we've done for our patients, and we should also have a specific time frame that those goals are set up for our patients. As a nurse, we have to utilize critical thinking and clinical judgment. And as you continue through your nursing program, you will develop those skills, and then you will begin to fine-tune them as you start your practice as a professional nurse. This graphic on the right was retrieved from the NCSBN, and it is the graph that displays the percentages of the different topics that will be tested on the NCLEX. If you have not already, please take a chance to look at the detailed NCLEX test plan from NCSBN. So let's talk about fluid and electrolytes. So if you are looking at your patient, it's important for you to review their health history and laboratory data and perform a clinical assessment. Many health problems can cause changes in balance of fluids and electrolytes. The nurse should be prepared to manage the client with imbalances. So it's essential for us to understand that adults, 50 to 60% of the body weight is water, and for infants, 75 to 80% of the body weight is water. So 2/3 of bodily fluid is intracellular fluid, that it means it's within the cells, and then 1/3 of body fluid is extracellular fluid. It's important for us to understand that 1 kilogram or 2.2 pounds of body weight is approximately equal to 1 liter of fluid. So what's important about that? It's important if your patient is on a daily weight, and let me just digress for a moment, because the most important thing that for you to understand about daily weights is that they should be taken in the morning, first thing after the patient empties their bladder, after they void. It should be taken at the same time in the morning after they void. So if your patient has a weight gain or weight loss or a significant weight gain or loss, especially of more than 2.2 pounds, you should be concerned, because you're going to be wondering, okay, well, where did that 2.2 pounds of weight come from? And probably your patient may be retaining fluid. So that's the importance. One of the importance of daily weight when it comes to fluid and electrolyte balances. Okay, so here are a list of the different types of intravenous fluids. So we have the isotonic fluids, the hypotonic and hypertonic fluids. So isotonic fluids consist of a normal saline, lactated ringers, 5% dextrose in water. So the indication for isotonic fluid is for the treatment of vascular system fluid deficit. The characteristics for intravenous fluids of the isotonic type is concentration that is equal to plasma, and we want to prevent fluid shift between compartments in our patient. So for the hypotonic fluids, so the indication for use of hypotonic fluids will be treatment of intracellular dehydration. So the characteristics of this hypotonic fluid is lower osmolality than the extracellular fluid. There's a shift in fluid from the extracellular fluid, there's a shift of fluid from the extracellular fluid to the intracellular fluid. So those are the characteristics of the hypertonic fluid, and the different hypotonic solutions are 0.45 or half normal saline, and 2.5% dextrose in 0.45% saline or half normal saline. The next intravenous fluid is hypertonic. And so the indication for using hypertonic is only used when serum osmolality is critically low in your patient. So the characteristics of hypertonic fluids is that the osmolality is higher than the extracellular fluid, and there's a shift of fluid from the intracellular spaces to the extracellular spaces. So the different types of hypertonic solutions that you may see, and these are not frequently given, well, they may be depending on your type of care, but as a normal everyday use, we don't see these every day unless you're in a critical care setting if you're an ICU nurse. 10% dextrose in water, 50% dextrose in water, 5% dextrose in normal saline, 5% dextrose in half normal saline, and 5% dextrose in lactated ringers. All right, so those are the intravenous fluids, the different types, isotonic, hypotonic, and hypertonic. More than likely, the common one that you will see is the isotonic fluid, which is the normal saline, the lactated ringers, and the D5W. Let's look quickly at the electrolyte values. So here is a table displaying the electrolyte values. You must memorize these values. There's no way to get around it. It is very essential for you to memorize these values. This will be something that you will probably see on the NCLEX, so please take the time to memorize these values. The value for sodium is 135 to 145. Potassium, which is K, is 3.5 to 5.0. Calcium is 9 to 11. Magnesium is 1.8 to 3. Chloride is 96 to 106. And phosphorus is going to be 3.0 to 4.5. Okay, let's now talk about fluid electrolyte imbalance. So let's first start by talking about fluid volume deficit. Fluid volume deficit. So fluid intake is less than the needed to meet body requirements when the patient has fluid volume deficit. The most common type is isotonic dehydration. So the contributing factors to fluid volume deficit are excess GI and or renal loss, diaphoresis, that means your patient is sweating, fever, long-term NPO, that means nothing by mouth, hemorrhage, insufficient intake, burns, diuretic therapy, aging. Older adults have less body water and decreased thirst sensation. So the manifestations of fluid volume deficit in your patient will be weight loss, dry mucous membranes, increased heart rate and respirations, thready pulse, capillary refill less than 3 seconds, weakness, fatigue, orthostatic hypotension, poor skin turgor, and the late signs or late manifestations of fluid volume deficit will be oliguria, decreased CVP, central venous pressure, flattened neck veins. So the diagnostic procedures you can expect to see for a patient with fluid volume deficit is testing and looking at their serum electrolytes, their BUN, their creatinine, their hematocrit, and their hemoglobin. We also may be looking at their urine specific gravity and the osmolarity of their urine. So collaborative care and nursing interventions for this patient with fluid volume deficit will monitor their vital signs, their pulse quality, and amplitude. We will also monitor skin turgor, and older adults will check the skin over the sternum or the forehead, as we know that the older patient has a loss of that subcutaneous fatty tissue. So we really have to be careful where we check for skin turgor. And also their skin has a loss of elasticity. We will also maintain strict eyes and nose intake and output for this patient, and output should be at least 0.5 milligrams per kilogram per hour. So we want to make sure that this patient has at least 30 mLs of urine output per hour. We'll weigh the client daily. We will monitor laboratory data. And we'll also seek to correct the underlying cause. Why is the patient in fluid volume deficit? So for fluid replacement, we will try to increase the oral fluid intake and initiate oral rehydration solution if the patient is able to tolerate it. IV fluids for severe dehydration, maintain as prescribed, making sure that we always assess the IV site as the fluids are being administered to the patient. Monitor the patient's response to therapy and initiate all fall precautions. That is very important, especially for your elderly patients. Medications may be electrolyte replacement and IV fluids. Okay. So now let's discuss fluid volume excess. Fluid volume excess is fluid intake or retention, and it's greater than the body needs. So the potential contributing factors to fluid volume excess is kidney failure in the late stages or late phases, heart failure, cirrhosis, interstitial to plasma fluid shifts, for example, hypertonic fluids with burns, excessive water intake, long-term corticosteroid therapy. So the manifestations of fluid volume excess in your patient may be cough, dyspnea, crackles, increased blood pressure, tachypnea, and tachycardia. Bounding pulse, weight gain. Remember, 1 liter of water is equal to 1 kilogram of weight, which is also equal to 2.2 pounds. Another manifestation is going to be possibly jugular vein distension, JVD, increased central venous pressure, pitting edema. So the diagnostic procedures that may be decreased due to hemodilution, we have to keep that in mind, is serum electrolytes, BUN, creatinine, and hematocrit, urine specific gravity and osmolarity, a chest x-ray if respiratory complications are present. So that's why assessing their lung sounds is especially important in your patient with fluid volume excess. Collaborative care with your nursing interventions include monitoring the respiratory rate, the symmetry, and the effort of respirations. Monitor breath sounds for signs of pulmonary edema. Monitor for edema and measure pitting edema on a scale of +1 being minimal all the way up to +4 is going to be severe. Monitor dependent edema by measuring circumference of the extremities. Monitor for ascites and measure abdominal girth daily. Weigh the client daily. Maintain strict intake and outputs. Monitor the vital signs. Administer diuretics, osmotic or loop diuretics as prescribed. Limit fluid intake. Maintain skin integrity. Use semi-Fowler's position and reposition every 2 hours. Restrict sodium intake. So for electrolyte imbalances, really, again, it's important to make sure you understand those normal ranges for your electrolytes. And the function of the electrolytes, and I'm going to go back as I talk about the electrolytes a little bit. The function of the electrolytes is to maintain homeostasis. And so the electrolytes also help to promote neuromuscular excitability. It helps to maintain fluid volume, distribute water between fluid compartments, maintain cardiac stability, and these electrolytes also help to regulate acid-base balance. So let me talk a little bit about each of the major electrolytes. And so if you have too little of a particular electrolyte, it's going to be hypo. If you have too much, it's going to be hyper. So if you have too little, or if the patient has too little potassium, it is known as hypokalemia. And so the risk factors for hypokalemia could be due to adverse effects of medications such as corticosteroids, diuretics, digitalis, and the abuse of laxatives. The patient may also be experiencing body fluid loss such as vomiting, diarrhea, wound drainage, or NG suction. There may be excessive diaphoresis, kidney disease, dietary deficiency, or alkalosis. So the manifestations in your patient of hypokalemia will consist of muscle weakness, cramping, fatigue, nausea, vomiting, irritability, confusion, decreased bowel motility, paresthesia, dysrhythmia, flat and or inverted T wave in the EKG or the ECG. So your interventions for your patient that has hypokalemia, you want to monitor their respiratory status, initiate fall precautions, initiate and monitor potassium replacement therapy, oral or IV. Monitor their ECG, monitor their I's and O's, monitor arterial HCO and pH, HCO3 or their bicarb and pH, provide client education, and then dietary sources of potassium as well as medications will be given. The important thing to understand about potassium, and you probably will see this on NCLEX or test questions, is that you will never give potassium in an IV bolus, and it must be diluted. Okay, do not push vitamin K quickly. It must be given slowly over an extended period of time. Okay, do not give potassium if the IV is in the hand because it will actually burn. Okay, so those are some things to think about when your patient has low potassium or hypokalemia. So let's now look at hyperkalemia when the patient has too much potassium. So the risk factors for hypokalemia consist of renal failure, adrenal insufficiency, acidosis, excessive potassium intake, medications, potassium-sparing diuretics, and ACE inhibitors. The manifestations of a patient with hyperkalemia is tweaked T waves on the ECG, ventricular dysrhythmias, muscle twitching, and paresthesia, and that's in the early phase. In the late phase, you will see ascending muscle weakness and also increased bowel motility. So your interventions for your patient with hyperkalemia, you will monitor their ECG, monitor bowel sounds, initiate dialysis, dietary restrictions and teaching should take place, and we'll administer the medications, possibly Clectrolyte, and we must monitor bowel sounds as we administer Clectrolyte, 50% glucose with insulin, calcium gluconate, bicarbonate, and loop diuretics. The next electrolyte we're going to talk about is sodium. So too little sodium is hyponatremia. The risk factors for a patient with hyponatremia or how they may become hyponatremic: GI loss, SIADH, adrenal insufficiency, NPO status, restricted sodium diet, water intoxication, excessive diaphoresis, and the medications they may be on that pose risk factors are diuretics, anticonvulsants, SSRIs, lithium, and demeclacine. So the manifestations of a patient with hyponatremia: they may be weak, lethargic, confused, they may have seizures, headache, anorexia, nausea, vomiting, muscle cramps, twitching, hypotension, tachycardia, weight gain, and edema. Your interventions will be sodium replacement, oral, through a GI tube or IV, daily weights, restrict oral fluid intake, maintain strict I's and O's, and the medication given may be conivaptan hydrochloride. Conivaptan hydrochloride. Okay, so it's important to note that the risk with hypertonic solutions is cerebral edema. So we also have to monitor for signs and symptoms of increased intracranial pressure. So for sodium, if the patient has too much, it's hypernatremia, and the risk factors include dehydration, GI loss, hyperaldosteronism, hypertonic tube feedings, diabetes insipidus, kidney failure, burns, heat stroke, corticosteroids, and the manifestations include fever, swollen dry tongue, sticky mucous membranes, hallucinations. Lethargy, restlessness, irritability, seizures, tachycardia, hypertension, hyperreflexia, twitching, and pulmonary edema. So the interventions for your patient with hypernatremia is daily weights, strict I's and O's, their intake and output, seizure precautions, IV infusion of hypotonic or isotonic fluids, diuretics, dietary sodium restriction and education, increase oral fluid intake. Now let's look at calcium. So too little calcium is known as hypocalcemia. So hypocalcemia risk factors include hypoparathyroidism, hypomagnesemia, kidney failure, vitamin D deficiency, inadequate intake, GI loss due to wound drainage or diarrhea. The disease process may be due to celiac disease, lactose intolerance, Crohn's disease, or alcohol use disorder. The manifestations of hypokalemia include tetany, cramps, paresthesia, dysrhythmia, Trousseau sign, Joseph's sign, seizures, hyperreflexia, impaired clotting time. So the interventions for your patient with hypokalemia will be seizure precautions, IV calcium replacement, daily calcium supplements, vitamin D therapy, and will monitor for orthostatic hypotension, dietary increase, and education. Please note that IV calcium must be administered slowly and the site monitored for extravasation. It is diluted in D5W, never in normal saline. Calcium has an inverse relationship with phosphorus. So that's really, really important. Just like potassium, we have to be careful when we are administering potassium. We have to use the same care when we are administering calcium to our patients. Now let's talk about hypercalcemia. So this is too much calcium. The risk factors include hyperparathyroidism, malignant disease, prolonged immobilization, dehydration, vitamin D excess, thiazide diuretics, lithium, glucocorticoids, digoxin toxicity, overuse of calcium supplements, and hyperthyroidism. The manifestations of hyperkalemia in your patients will be muscle weakness, hypercalciuria or kidney stones, dysrhythmias, lethargy, coma, hyporeflexia, pathologic fractures, flank pain, deep bone pain, polyuria, polydipsia, dehydration, hypertension, nausea, and vomiting. Interventions for your patient with hypercalcemia. Increase mobility. So you will increase their mobility, give isotonic intravenous fluids, dialysis, cardiac monitoring. The medications that may be prescribed: furosemide, calcitonin, and glucocorticoids. Bisphosphates may be given, and calcium chelators may be given. Calcium again has an inverse relationship with phosphorus. Now let's discuss magnesium. Too little magnesium is known as hypomagnesemia. So risk factors for hypomagnesemia or magnesemia include GI loss, alcoholism, hypocalcemia, hypokalemia, DKA, hyperparathyroidism, malabsorption, the patient's on TPN, total parenteral nutrition, laxative abuse, acute MI, myocardial infarction. Medications that are risk factors include cisplatin, cyclosporine, diuretics, amphotericin B, and aminoglycoside antibiotics. The manifestations of your patient with hypomagnesemia will be paresthesias, dysrhythmia, the Trousseau sign, the Chosovich sign, agitation, confusion, hyperreflexia, hypertension, insomnia, irritability, anorexia, nausea, vomiting, and dysphagia. The nursing interventions include seizure precautions, monitor swallowing, dietary measures, and education. Will administer medications such as IV magnesium sulfate, PO magnesium salts. We will monitor the patient's urine output and monitor their respirations. Please note to monitor for signs of magnesium toxicity when you are replacing via IV, and treat with calcium gluconate if there is toxicity of magnesium. So if the patient has too much magnesium, which is hypermagnesemia, the risk factors include renal failure, excessive magnesium therapy, adrenal insufficiency, laxative overuse, lithium toxicity, extensive soft tissue injury or necrosis. Manifestations of hypermagnesemia include hypotension, drowsiness, bradycardia, bradypnea, coma, cardiac arrest, hyporeflexia, nausea, vomiting, and facial flushing. Interventions for hypermagnesemia include mechanical ventilation, IV fluids to include lactated ringers or normal saline. Medications will include IV calcium gluconate, loop diuretics. We will also monitor for respirations and blood pressure for these patients. Monitor deep tendon reflexes as well. Please note that magnesium should not be administered to patients in renal failure. Lastly, we will look at phosphorus. So hypophosphatemia, too little phosphorus. The risk factors for patients with this condition include vitamin D deficiency, refeeding after starvation, alcohol use disorder, DKA, alkalosis, hypomagnesemia, hypokalemia, excessive loss of body fluids, sweat, diarrhea, vomiting, hyperventilation, and burns, as well as TPN and the overuse of antacids. So the manifestations of hypophosphatemia in your patients may be paresthesia, muscle weakness, bone pain, and deformities, chest pain, confusion, seizures, and nystagmus. Interventions for your patients with hypophosphatemia: oral phosphate replacement, careful IV administration of phosphorus in severe cases, gradual introduction of solution for clients on TPN, and protect the patient from infection, dietary management and education, and seizure precautions. Another reminder, phosphorus has an inverse relationship with calcium. Phosphorus, if the patient has too much phosphorus, it's called hyperphosphatemia. So the risk factors for hyperphosphatemia are renal failure, chemotherapy, acute pancreatitis, high vitamin D, high phosphorus intake, hypoparathyroidism, excessive enema use, or acidosis. Manifestations of hyperphosphatemia include tetany, cramps, paresthesias, dysrhythmias, Trousseau sign, Chosovich sign, hyperreflexia, anorexia, nausea, vomiting, soft tissue calcifications. Interventions for hyperphosphatemia include vitamin D, aluminum hydroxide, diuretics, IV normal saline, dialysis, and dietary management, as well as education. And an important note that phosphorus and calcium share an inverse relationship. So now that we've talked about our major electrolytes, we've talked about fluid volume excess, fluid volume deficit, let us shift gears and talk about acid-base balance. So acid-base balance is very important as we are looking at our patients, and you have to pretty much memorize these values. You have to memorize the normal pH for a human being is going to be 3.5 to 4.5. The normal PCO2, and that is your partial carbon dioxide, is between 35 and 45 milligrams of mercury. The normal bicarbonate for humans is 22 to 26 milliequivalents per liter. So on this slide, we have the acronym ROAM. So when we think about our body being able to compensate and maintaining the correct pH, the body compensates in two ways. So the lungs help us to compensate, and that you should be thinking respiratory, and you should be thinking PCO2 when it comes to acid-base balance. So for metabolic compensation, you should be thinking about the kidneys, and you should be thinking about HCO3, also your bicarb, also known as your bicarb. So keep in mind that the lungs will actually start working faster, right? Because which one's going to start working faster, your lungs or your kidneys? Well, I can start breathing heavily right now, right? But it's going to take some time, probably a couple or maybe a few days for my kidneys to start compensating. So keep that in mind as you are working through your acid-base balance problems. The other thing to keep in mind on this chart, it shows you that as pH decreases in your patients, and that means it goes below 7.35, the patient is becoming more acidic. If the pH goes above 7.45, the patient will become alkalotic, okay, or alkalosis will be present. Okay, so that's something to keep in mind. For your PCO2, as the value goes above 45, we're looking at acidosis, and if the actual PCO2 value goes below 35, we're looking at respiratory alkalosis. They're becoming more basic. So when we look at HCO3 or your bicarb, if the value goes below 22, we are looking at acidosis, particularly metabolic acidosis. If the HCO3 or the bicarb value goes above 26, we are looking at metabolic alkalosis. Okay, so it's important to memorize those values and understand what they mean. So the acronym ROAM means respiratory is opposite. So in respiratory imbalances, the affected values are inverse, and that means as opposed to we're using the actual pH as our guide. We're using the pH values as our guide. And so for metabolic, they are equal. In metabolic imbalances, the affected values move in the same direction, okay, the same direction as pH, okay, as our pH value of 7.3 to 7.45, okay. So ROAM is the acronym that we use for that. So on this next slide, I found something that is pretty neat. This is a slideshow it's a slide that talks about whether or not the patient is fully compensated, partially compensated, or uncompensated at all. And so we'll look at, on the next couple slides, we'll actually show an example problem. But in the first block where you see fully compensated, the pH is normal. And so the bicarb level is actually acidic. So it's in the acidic or acidosis column. And so the next thing you'll see is the PCO2, or the partial carbon dioxide, is alkalotic. And in this case, the patient is fully compensated, meaning that the pH is normal because the lungs and the kidneys have worked together in order to establish or maintain a normal pH. Okay, so in the next square, you'll see partially compensated. So it looks like for this particular patient, their respiratory status, their PCA2, PaCO2, their partial carbon dioxide is acidotic, so they're in acidosis. And so for the pH and their bicarb is actually in their alkaline or alkalosis. So this patient is partially compensated. And in the next case, this patient is uncompensated, okay, because the pH is alkalotic, the bicarb is alkalotic. Okay, so this patient is uncompensated. And so we'll do one problem and we'll see how that actually works in play. Something I want to talk about a little bit, though, before we do our sample problem is let's look at metabolic acidosis. So we know metabolic, that deals with the kidneys. When we think acid, okay, there's too much acid. So what are the risk factors for a patient that has metabolic acidosis? Well, they may have diarrhea, fever, hypoxia, starvation, seizure, overdose on salicylates or ethanol, renal failure, DKA, dehydration. The manifestations of metabolic acidosis, we have to maintain their vital signs, and their vital signs will probably show bradycardia, weak pulses, hypotension, tachypnea, flaccid paralysis, confusion, hyporeflexia, lethargy, warm, flush, dry skin, and Kussmaul respirations. Interventions for a patient with metabolic acidosis include treating the underlying cause and administer fluids and electrolytes. Let's now shift gears and talk about metabolic alkalosis. Risk factors for metabolic alkalosis include ingestion of antacids, GI suction, hypokalemia, TPN, blood transfusion, prolonged vomiting. The manifestations of metabolic alkalosis include dizziness, paresthesia, hypertonic muscles, decreased respirations, and the interventions for metabolic alkalosis include treating the underlying cause, administering fluids, as well as electrolytes. Let's now talk about respiratory acidosis. The risk factors for respiratory acidosis, keep in mind now we're thinking about the lungs. The risk factors include respiratory depression, pneumothorax, airway obstruction, inadequate ventilation. The manifestations of respiratory acidosis include dizziness, palpitations, muscle twitching, and convulsions. The interventions for a patient with respiratory acidosis include maintaining a patent airway, reversal agents for narcotics, regulation ventilation therapy, bronchodilators, and mucolytics. Now we'll talk about respiratory alkalosis, too much base. Risk factors for respiratory alkalosis: hyperventilation, hypoxemia, altitude sickness, asphyxiation, asthma, and pneumonia. The manifestations of respiratory alkalosis include tachypnea, anxiety, tetany, paresthesia, palpitations, chest pain. The interventions for respiratory alkalosis are regulating oxygen therapy, reducing anxiety, and rebreathing techniques. Now we are going to take a look at our sample problem. So this is ABG Tic Tac Toe. Ricky's grandmother is suffering from persistent vomiting for 2 days now. She appears to be lethargic and weak and has myalgia. She is noted to have dry mucous membranes, and her capillary refill takes greater than 4 seconds. She is diagnosed as having gastroenteritis and dehydration. Measurement of her arterial blood gas shows a pH of 7.5, partial oxygen of 85 millimeters of mercury. Her PCO2 is 40 millimeters of mercury, and her bicarb, or her HCO3, is 34 millimolars per liter. What acid-base disorder is shown in Ricky's grandmother? So I will give you a few moments to think about this. So remembering what the normal values are for pH, you will see, is the pH showing a patient that is in acidosis, or is the pH normal, or is the pH showing a patient that is in alkalosis? Then you will look at your PCO2. Your PCO2, so your partial carbon dioxide, is that showing acidosis, a normal value, or alkalosis? Then you'll look at your bicarb, your HCO3. Is that showing acidosis, a normal range, or alkalosis? So wherever those values are, you fill them in the tic-tac-toe grid. Take a moment to do that, or pause the video if you need to. All right, well, here is the answer. The PCO2 value is actually within normal range of 40, right? Because the normal range of PCO2 is 35 to 45. Our pH is actually showing that this patient is alkalotic, or they're in alkalosis, because the normal pH range is 7.35 to 7.45. So we have put the pH in alkalosis. The bicarb has a value of 34, and so we know that the normal range of bicarb is 21 to 28, so that is showing alkalosis. So we have metabolic alkalosis, which is uncompensated. And so here's some tips that are on the left-hand side. So if all three values are normal, and we're talking about the pH, the partial carbon dioxide, as well as the bicarbonate, if all three are normal, then the ABGs are normal, which is not the case in this particular scenario. If two are abnormal, ABGs are fully compensated when the pH has returned to normal. And so we know that in this case, the pH is not normal, okay? It is alkalotic, okay? So it's uncompensated when two values are abnormal. And so yes, we see that two values are abnormal. The pH and the bicarb are abnormal. So if three are abnormal, the ABGs are partially compensated. So in this particular case, Ricky's grandmother is suffering from metabolic alkalosis, which is uncompensated. Okay. At this time, that concludes our presentation on fluid electrolyte acid-base balance. There's a lot of information. I may have used some acronyms that you are uncertain about. Please feel free to mention that in class, or look them up before class and come with some more questions. This concludes our huddle for today. And remember, think like a nurse. See you next time.